morning, friends. I am Dr. Yugal Mishra, Chief of Clinical Services and Head of Cardiac Sciences, Manipal Hospital, New Delhi. With me, I have two very important guests, Dr. Guillaume Lebreton from L'Hôpital Hospital, Paris, and Mr. Giampietro from Syncardia, worldwide.
Good morning.
Sir, welcome to this important event of annual meeting of Indian Association of Heart and Lung Transplant Society. Now, let's move on to this important interview where I am going to interact with two authorities in the field of total artificial heart. We are going to discuss particularly the heart transplant post total artificial heart. To start with, Professor Lebreton, can you give a brief idea what is the status of total artificial heart worldwide?
Right. First of all, thank you very much for your invitation. It's a pleasure for me to be in India and in Delhi today in this great meeting. Total artificial heart is something we use in our institution in Paris, in La Pitié, since the beginning of our experience, as you know. And it's a device which is very, very interesting and very efficient as a bridge to transplantation. And today I think that this is the gold standard for the biventricular failure as a bridge to transplantation. Because with good candidates, with the good timing, you will have the good result as a bridge to transplantation. By example today, because probably with the time we learn in our experience, we improve our result, and the 5 last years, the result in terms of survival after transplantation, after total artificial heart, in our experience, it's 80% at 1 year. So it's quite the same thing that for the other patient on the waiting list. So this is why we consider that today this is a very efficient tool, a very efficient device as a bridge to transplantation for biventricular failure. And if you look in the Intermax report, you can see several experience, and I think it's very, very important, but we will discuss of that, I think, in a few minutes. Yes.
Right. So let's talk of particularly the experience worldwide. We know that the Syncardia, they have got 1900 implantation worldwide, and in the France now Carpentier's work has given a Carmet, and I witnessed one of the presentations in the Carmet from Astana, Kazakhstan, where they have used this device in 3 patients, and successfully they transplanted all those 3 patients. Now, besides bridge to transplant, there are a lot of efforts that can it be used as a destination therapy, which FDA has not given go ahead. But I know that Syncardia is working on this one, and Carmet is working on this one. There are some experimental work going on to whether it's a Cleveland heart, whether it's a Ren heart, and likewise. So what you feel, Joe, at this stage, can the Syncardia is ready to move on to a destination therapy? Or the technically you are foolproof for this kind of therapy?
So currently, with the patients that are on the total artificial heart, prior to the Freedom Driver where we send patients home, the majority of our patients were transplanted within the first 2 years. With the Freedom Driver, now that the patients are at home, we've had patients past 2 years, 3 years, 4 years, 5 years, and we have a patient in North Carolina that is coming up on 6 years of total artificial heart support at home to stay as a destination device. So where we are currently is we have filed with, submitted for full approval with the FDA for destination therapy with our trial, and we have we're currently working on the next generation Freedom Driver called the XQS that is designed for patients at home for a better quality of life. So I think long term we are working on those goals. We're putting the steps in place and moving to the next part of our spectrum with destination therapy.
Thank you. So, Professor,
if I can add something,
right.
I think that the question, but maybe it's a little bit provocative, is the CARMAT ready to be a biventricular assist device? Because today I think we can't put on the same level CARMAT and SynCardia.
Right.
I can tell that very freely because I'm not from SynCardia and I'm from France, and I perform 2 CARMAT implantation on a patient, so I know the 2 devices, and it's not the same thing because with the CARMAT, as you know, okay, in Astana they had experience with few patients with some interesting result. Few patients.
Right.
With SynCardia, we speak of hundreds patients.
Absolutely.
So it's totally different, and the time and the time of support under SynCardia sometimes it's very long, months and 2 or 3 years. 2 years. So it's totally different. With CARMAT, we don't have that. Just few months and a very short time of support before transplantation in an easy situation.
Right.
I think it's not the same thing, and it's important to say that. Yes.
And so discuss about little bit of the technology in these 2 devices, the CARMAT, the right ventricle and left ventricle, they contract in a different cycle, not simultaneously, while the SynCardia, the contraction is the same. So this is again but this also that's the biological tissue and the lining different. This is purely a mechanical one. So these are the, we don't want to go into that detail, but what I want to focus particularly here, that you have already narrated that you have extensive experience of total artificial heart post, and then putting in the transplant. Now, if we go to the Copeland study which was published in 2004, where he analyzed the 2 group, historical patients where he has seen the patient who were transplanted after total artificial heart and the patient who just waited on medical therapy, and definitely the results were much superior with the patient who had a total artificial heart as a bridge as compared to the medical therapy. Now, how you highlight what are the advantage of total artificial heart in that group of patient and why the result is so superior? Can you give few points that these are the reason, that's why the total artificial heart as a bridge to transplant is much superior than LVADs, than optimized medical therapy?
It's a really easy question because it's superior to LVAD for patients with a biventricular failure.
Right.
With a biventricular failure, with an LVAD, it will fail.
Right.
And another thing which is important, I think, to consider is that now it's possible for us to use 2 LVAD to have a biventricular support with a continuous flow device. Okay. But an LVAD, it's designed for the left ventricle, not for the right ventricle.
Right.
And if you look in the literature, several experience about a continuous flow pump used as a right ventricle assist device, you have some problem of thrombosis in 1/3 of the patient, thrombosis of the pump. And it's sometimes very difficult to find the good positioning in the right ventricle, in the right atrium. So it's not designed for that. This is the difference with SynCardia. SynCardia, it's a device which is designed for that, designed for biventricular support, and this is why it's so efficient, I think. And this is very important to underline. And the other thing which is important, I think, to underline is that even if the literature, when you look the result, you have sometimes some poor result with SynCardia and interesting result with biventricular support. It's important to consider something. It's important to consider that sometimes we don't speak of the same patient. And this is why I said in the beginning of my presentation yesterday, it's important to have the good candidates. And patient with a biventricular failure are the patient in the sickest situation. They are the sickest patient. So we don't speak of the same patient, and I think it's important to consider that. I think also it's important to consider that result will depend on your experience. And in the last Intermax report, by example, it's very well described. Keklin described that for in center with a volume of TH more than 10 each year, they have better result than in center with less than 10. And last but not least, the Intermax level, it's also very, very important. So it's not so easy to do a comparison between the two strategy, between the two devices, between BVAD and total artificial heart, because in fact, most of the time we don't speak of the same patients. So it's not so evident. But in our experience, because we use the two strategies, SynCardia is what is designed for biventricular failure. It's a very powerful device, very efficient, and with some good result if you use it for good candidates at the good timing.
Thanks. So, Joe, move on to the technicalities of the device. You are working in SynCardia since last 8 years.
Yes, sir.
We all know that the biggest complication with the total artificial heart is multi-organ failure. Now, is the companies working on or strategizing themselves to come out with a device where we can minimize the multi-organ failure?
Yes, sir. So one of the things I mentioned briefly is that we're working on the next generation driver. When you look at device failure per se, the device failure isn't the device itself. It's when you classify device failure, it's switching out different controllers. That falls into that spectrum. So the biggest project we have at SynCardia is the next generation portable driver to go home. So this driver will replace the Companion 2 and the Freedom driver for one. So when we implant the patient to discharge to transplant, they will go on one driver. So we've listened to the customers, we've listened to the patients, and we've listened to the community on what we need to improve on in our next generation. So that's currently what we're doing. But as far as the ventricles, the complication rate with device failure is very small. The device where we see the device complications or device issues is switching out the driver from one driver to the next. That's where the device failures are in the reports. So it's not the device itself, it's actually the controllers.
Right, thank you. So the move on to this device specific, Professor Lebreton. You have extensive experience, and let's have advantage of that experience. So just can you explain us that when you select a candidate for total artificial heart and you have the most important thing in mind that you are going to transplant this case. So what are the technicalities which are important when you are deploying your total artificial heart in a patient where you are going to do a transplant in a future? So how you figure out, how you basically evolve the techniques since these years that you may have least complication when you explant this device and do the transplant?
I think that the key point is that when you perform the TH implantation, you have to prepare the transplantation. And I think this is the key point. So
it means that you are saying that when you are deploying the device, it means that this is a candidate for transplant. So you are preparing a candidate for transplant with a total artificial heart as a bridge for a short time. So that's the key thing in this area.
You have to prepare the patient for the transplantation. This is your goal.
Right.
So during the implantation, by example, it's important to avoid to add something like Teflon or things like that, because you will have some adherence.
Right.
And it's also important to add some, and it was very well described yesterday by you in your lecture. It's very important to add some small Gore-Tex or things like that around the vessel everywhere to make easier the harvesting when you will have to perform the transplantation. And doing that, performing an heart transplantation after a TEH, it's not so difficult. It's a surgical challenge for
Right,
sure,
right.
but it's not so difficult. It's not a nightmare. If during the implantation of the syncardia, you prepare the next step, and I think this is the key point.
So can you little bit elaborate the recipient size and the TH, how you can match that? What is the importance of recipient size?
Oh, in fact, what is important is to have a CT scan before the surgery in order to have an idea of the positioning of the device in the thorax. It's possible to have a three-dimensional reconstruction, but even if you don't have that, with the experience, it's possible to see if it's possible to put a total artificial heart in a chest, or if it's not possible, not reasonable. So this is one of the criteria for the selection of the good candidates, but it's not the only one.
Only one. So anyway, we are not going to discuss much about the candidates' suitability for this one, because we have to concentrate more on the heart transplant after that. So can you elaborate that what are the things which we have to keep in mind when we are explanting the total artificial heart before doing a transplantation? What are the key factors? What are the important factors which we have to keep in mind? So there may be less bleeding after explantation. There may be less damage to the organ like aorta, pulmonary artery, whatever is left out. How you make sure that we can minimize? Or other word, when you are deploying the total artificial heart, you make certain things which may reduce the complication during explantation.
Yes, this is what I described. It's important to prepare everything, to use Gore-Tex, things like that.
Yeah.
Sometimes we use also Cosil, by example, to avoid some adherence in the thorax. This is something which is very important. Another thing is that you have to avoid during the implantation to have a too large harvesting in the chest
Right.
to avoid adherence. So
Right.
you just cut the vessel when it's necessary, no more. And it's important to avoid to have some adherence everywhere, and it will make easier after the surgery during the transplantation. But it's still a surgical challenge for sure.
Right. So these patients are already on anticoagulation, right? Now, so how you prepare when you are supposed to stop the anticoagulation so that you have a appropriate functioning of those valves, and then you have to switch on to the, because you know the issue is that you get a heart, you are not sure when you are going to get a heart. So for a planned case, you can plan out to stop anticoagulation beforehand. Now here you have to, now you get a message that you are getting heart in 6 hours or 8 hours time. So how to manage that? That's very important to know how you are able to discontinue or avoid a bleeding because of anticoagulation, which are mandatory in these patients.
I don't know what you can say about that, but I can say what we do in Paris. We don't stop anticoagulation.
Till
No, it's not possible. I think.
One of the things I talked with Dr. Copeland on, because the question comes up all the time, because
Right.
the clinical team, we're typically not there for the transplant because they come up and we're usually different places. But I spoke with Dr. Copeland, and one of the big things that he discussed with me over the phone was when you know you have a patient that's getting transplanted and you bring them back in the hospital, they're on Coumadin at home. If you can switch them back to heparin prior to the procedure, then you can give some FFP, while they're in the hospital right prior to the transplant, because if you try to correct all the coagulopathies or bleeding post-operatively and you give the patient a bunch of volume, then you can potentially send the patient into right heart failure post-operatively. That was one of the things that Dr. Copeland stressed to me over the phone, was that when you know these things ahead of time, if you can bring the patient back on and put them back on heparin, then it's easier to control things in the operating room.
now, so another question which I want to put to Professor Lebreton is that the patient who is on total artificial heart, they don't require cardiac drugs as such per se, because there is mechanical heart. Now the patients who are on medications, they are already loaded with a lot of lot of drugs, and subsequently after transplant that continued for some time. Here there is no drug, and then you are switching over and you are putting off the total artificial heart and switching over to the donor's heart. So how you can switch, how you should calculate, or how you can restart some drugs, how you manage that medication in this particular group?
Oh. In fact, it's not so different than for the other transplantation, because when you perform a transplantation, even if the patient had some drug before, when you put the new heart, you change everything. So for this patient, for sure, there is no inotropes. Sometimes there is some vasopressor during the CPB.
Right.
But after, when we remove the heart under CPB, and when we put we remove the total artificial heart, and we perform the transplantation. After we start dobutamine. In France, we use dobutamine. We use dobutamine like for another heart transplantation, and it's exactly the same thing. So it's not a challenge. The problem is not there. I think that we can discuss of the transplantation and that TEH, but it's a surgical challenge, okay, like a redo surgery, but you know that, like me, it's exactly the same thing. It's not so difficult. It's not, I think it's not necessary to focus about that. And what is important is to focus about the good candidates, right, and the good timing, because I can tell you with our experience that when we failed, it's because of that. It's because we tried to put a total artificial heart for a patient in a too critical situation, under ECMO support since 2 weeks, 3 weeks, infection, pulmonary edema. In such a situation, it's difficult, and we will have some poor results. So it's important, I think, it's necessary to go step by step. And the first step, this is the selection. And this is what is the most important. When you will have performed the selection, the implantation, the management, all of that, it's not difficult. And after the transplantation, it's the same thing. It's for an experienced, it's necessary to have some experience when you are a surgeon to do that, but it's not so difficult. It's not the key point. The key point is to choose the good timing for the good candidates and the good strategy, for sure. I don't know if you agree with me, but...
Oh, completely.
Probably. And the most important with the total artificial heart is our right ventricle is blood pressure, because the right ventricle is the key to the success. Whether it's a LVAD or is after transplant, the results are much better if we could able to preserve the right ventricle and the pulmonary artery pressure. And with the total artificial heart, this is the biggest advantage. We are preserving our right ventricle.
Yes,
now move on, and let me put a technical question to Joe.
Yes, sir.
Now, with 1900 syncardia transplant, extensive experience. Now, can we define today, based on syncardia, based on some new devices which are coming up, maybe CarMate, maybe Cleveland Heart, maybe Ryan Heart, whatever is.
Yes, sir.
Now, did we reaching close to an ideal total artificial heart, talk of recipient size independence, quite no noise, or no anticoagulation? I mean, these are some of the, like anticoagulation even again is a very important factor which leads to complication. Then have a long-term power supply, talk of easy surgical placement, talk of diagnostic telemetry and implantation, and forget. Is there something is happening in this area?
It's something that's happening at a slow pace. With the total artificial heart, even though it's been approved for a long time, getting to that next step with total biventricular failure is going to take some time. Right. With the LVAD community, with the Leviticus heart for just left ventricular failure, they're getting to that step for internal complete power source. But with the total artificial heart, with the severity of the patient's condition, they require more support, more equipment currently. I think eventually we will get to that point, but we're not there as of yet.
So, Professor Lebreton, to put in the question to you, as an end user, what do you want more in this technology? Now you have extensive experience of using Syncardia, you have used CARMET. What do you need for a better outcome of your patient? So what are the changes required at this juncture?
Yes, but I think that even if we can be very optimistic and enthusiastic, a lot of enthusiasm for VAD and total artificial heart, the gold standard is still heart transplantation. And because we have a lack of organs, because we can't give an heart for all the patients at the good time, we need a VAD and we need total artificial heart. And for patients with a biventricular failure, today, what is, I think, the most efficient device is total artificial heart to win some time and also to make eligible candidates with a biventricular failure to an heart transplantation. And also, last but not least, I think it gives some time and you give a chance for a biventricular patient. And it's something which is important because you have no other things. After, to answer to your question, what is the challenge? The challenge today is hemocompatibility and the power supply. By example, for the LVAD and the other VAD. For Syncardia, I think it's different because it's a pneumatic device. You have no choice. It's not possible to avoid to have a drive line. So challenge is not there. The challenge is to have a device which is quiet, and now with the new driver it's possible, and maybe to win in terms of biocompatibility, things like that. Because personally, I consider that Syncardia is just to win some time, to be a bridge to transplantation in few months or 1 year or 2 years. That's all. In my I consider in my strategy that TH is for that, not for destination, for the moment. So because the best solution is probably heart transplantation, I think.
Thank you. So let's talk of future of total artificial heart and penetration in Asia. Now, so far we know that the Syncardia is being maximally used either in the North America or in the Western Europe.
Yes, sir.
Now, what is the company's perspective to move further and have penetration to rest of the world? How you see today, considering the cost, considering the technology, considering the logistic, how you can envisage that, how early this technology can be available to our country like India?
Well, currently we, with our new president, Pete Spadaro, he has opened up Syncardia to global markets, and currently we're working to bring it to this great country of India. We're also working on other markets globally, Hong Kong, Taiwan, South America, Latin America, and some other places on the globe. So we are working on a global structure to release the total artificial heart, and currently India is at the top of our list.
Right. So, Professor Lebreton, your extensive experience, what we can have a takeaway messages from you to utilize this, how cautiously we should go to utilize this technology, considering economics, considering patient selection, considering is the India ripe at this stage? You have attended this meeting, there were representations. India is contributing in International Heart and Lung Society numbers, particularly heart. How you feel that this is the right time to grab this technology in this country?
I think this is the good time to start for you because it's something which is very efficient and it gives a chance for patients with a biventricular failure. And today we have no option for this patient. And what is safe, what is efficient as a bridge to transplantation for the good candidates, for young patients in a good situation, at the good timing, it's total artificial heart with Syncardia. Today this is the only device on the market so efficient in such a situation, in such a so critical situation.
Thank you. Thanks, Professor Lebreton and Joe, for giving your time for this important interview. Thank you. Thank you very much.
Thank you so much.
Thanks.